Good morning, everyone. I'm Ko from the Department of Psychological Medicine. So this morning, it's a great pleasure for me to introduce the next speaker. She's Dr. Surina Zaman Huri. So she just joined us last year as a lecturer, and she's a consultant geriatric psychiatrist, and she brings with her years of experience in geriatric psychiatry. So who better than her to give the talk for this morning, the second talk for this morning, when sleep won't come, the mystery of a senior's sleepless nights. So without further ado, I will hand the podium to her.
Okay, thank you, Prof. Go. I'm Surina. So today I will talk about the sleep issue in the elderly, and I believe it's quite common for us facing this problem when during our clinical practice. So this is my outline of the topic for today. So before we go through about the sleep issue in elderly, so we should, I will explain a little bit about the sleep cycle, because it's important for us to understand the sleep cycle, how the sleep cycle especially in elderly, because some of the patients that may perceive that my sleep pattern when I was younger and when I'm at the elderly age should be the same. So basically, from people to people, there are different pattern of the sleep. Basically depend on the age, recent sleep pattern, and it also if let's say there are involvement of the alcohol consumptions. And generally, for each individual, they will have around that 4 to 6 cycle per night. One sleep cycle involve REM sleep and non-REM sleep. This is one cycle. So overnight, every one of us would have around 4 to 6 cycle, and each cycle, which is include REM and non-REM, is around 90 minutes. So, so this is generally how the sleep cycle for every one of us. Okay, so this slide showing that the architecture of the sleeps for every one of us. So like I mentioned earlier, sleep divided into the REM and non-REM sleep. So this is generally how it looks like. So when we start sleep at the early of the night, it start with the stage 1 to stage 3 and followed by REM sleep. And when the night progress, the REM sleeps become longer and the sleep depth is become shallow. So this is generally how it looks like. However, what's the difference between that the younger people and older people? So in older people, unfortunately, the sleep latency is become longer. Generally, we have sleep latency is the time for us the time taken for us to fall asleep. So generally, it's around 30 minutes. So in elderly, the sleep latency is a bit prolonged. And also in elderly, they also have increased time awake after sleep onset. This is meaning that the durations of people who wakes up in the middle of night after they fall asleep. So in elderly, it's a bit longer compared to younger people. And the efficiency of the sleep is also decreased. Sleep efficiency meaning that how good you sleeping in the night. Okay, so this is generally what's the difference when compare the younger people to the and the older people. So this slide show that the differences between the young person and elderly person. So we can see that the above sleep architecture in the younger people, they are very nice pattern of the non-REM followed than REM, and you can see that very clear cycle. Compared to the older people, this is for physiological changes. It's not because of other problem. Generally, if we get older, this is how our sleep pattern. So we don't have that very nice, clear pattern compared than above. So they usually have that very light sleep, because as we know, REM sleep followed by non-REM sleep. Non-REM sleep, they have stage 1, 2, and 3. And the deep sleep is stage 3. So in elderly, the stage 3, they barely touch that. So that's the reason sometimes when elderly come to see us, they always complain that my sleep is not good. With slight sound, I wake up. So they always expected that, can I sleep like when I was younger? So generally, it's almost that if you understand the physiological of aging, so it's almost impossible for them to have like the good sleep as when they are younger, because physiological they really touch at the stage 3, so they most commonly have the light sleep throughout the night. So what's the impact of sleep disruptions? So sleep disruption always associated with cognitive impairment. And this is also can be like the earliest sign for neurodegenerative disorder. And poorer mental health, including depression and anxiety disorder, also can be the consequences of the sleep disruptions and risk of fall. As we know, in elderly, when they have lacking of sleep, the daytime they feel tired and a bit drowsy, so the risk of fall is increased. And greater morbidity due to the acute medical illness, and increase all-cause of mortality even after controlling other factors such as medication use, age, mobility, and baseline health risk, and poor quality of life. That's why the sleep disruption is very important, especially in the elderly. Okay, now we go into the sleep disorder, because the common complaint for elderly that come to see us is a sleep issue. But before we diagnose them to have a sleep disorder, we need to rule out a few other things. And it can be sleep issue can be a consequences of sleep disorder such as OSA, insomnia, environmental and behavior changes. Sometimes because of the changes of the routine, for example, recent festive season, there are so many people around, so also can affect their sleep, and can be due to secondary to the chronic diseases and medication. This is also important point that sometimes we overlook that. Okay, so so increased prevalence associated with various correlate with aging include that there are changes architecture sleep, like I mentioned earlier, the increase of the sleep latency, reduce the sleep efficiency, increase wakes after the sleep onset. So also can affect the medical, psychiatric, neurocognitive disease, untreated untreated pain, medication side effects, stressor like social isolation, discrimination, bereavement, and caregiving responsibility. This is all associated reason that can cause the sleep disruption in elderly. Okay, so could insomnia associated with depression in elderly? So the answer is yes, because in elderly, they may not presented with typical symptom of depression compared to younger people. For example, younger people, they always come to you with complaint that I feel sad, I have low mood, I'm not feel okay for the last few weeks. In contrast with the elderly, they not complain of feeling mood symptom. They always come to you, I cannot sleep. I cannot sleep like before. But when you ask about the mood symptom, they always deny. So in elderly, apart from the sleep issue, they always presented with more agitated behavior, complaint of pain, multiple pain, GI pain, and some hypochondriatic symptom, which is when we try to investigate, there are no reasons, cause of the organicity that we can find out. So that possibility that they also have the depression. And some diagnostic criteria also can be overlapped, like major neurocognitive disorder and physical illness. Also, these diseases also can be presented with the insomnia. And the prominent somatic complaint and insomnia is almost the main complaint of the people with depression in elderly, and prominent cognitive impairment. This is also quite common because some of the elderly patients come to us with complaint of I cannot sleep and I'm forgetful. Okay, so this could be the features of the depression in elderly, and more features in anxiety, agitation, and obsessional symptom in elderly when they presented with depressions. So, as I mentioned earlier, sometimes insomnia can be the only symptom of depressions. And there are studies also found that insomnia also a risk factor for new depression and depression that relapse. Okay, there are some recommendations of the treatment insomnia. However, if possible, we should try to avoid or minimizing usage of benzodiazepines, because it can also increase the risk of impact alertness, respiratory depression, and also risk of fall. Okay, before we conclude that the patients that come, elderly patients that come to us with the insomnia due to the sleep disorder, we should rule out other causes of poor sleep in older adult. So there are actually many. This is the thing that sometimes we overlook, because we thought that, okay, insomnia, no other complaint, no other reason that we can find out. So we immediately treat as a sleep disorder, but somehow there's a lot of reasons that, especially in elderly, there can be a reason for them to develop the insomnia. For example, there are medical problem, if they have lung issue, chronic pain, sometimes they have reflux issue, that's also can interfere their sleep. And psychiatric disorder, for example, depression, anxiety is known to have the poor sleep. And excessive napping, because sometimes our elderly patients, they don't have much activity at home. And when you check back, they most of the time, they spend their time during their time napping. So napping almost like a few hours. So if they sleep quite a lot, napping quite a lot in the daytime, it's no way for them to have a good sleep at the night. And some, they use coffee, alcohol, and medication, diuretics, beta blocker. This is some of the other medications. Sometimes we overlook because some, they come to you that they couldn't sleep. And when we ask what actually the reason you can't sleep, oh, I need to go to toilet for urination. So when we check, oh, also a patient is on diuretics. So instead of adding new medication to help a patient to sleep, we should actually try to at least prescribe or discuss with our colleagues, is there any other medication can substitute to for the medication, at least can help them to have a better sleep at night. So other than that, after we exclude other the causes, then only we can conclude could be the primary sleep disorder. Okay, this is another list of the medical illness associated with the sleep disruption. I won't go through every single thing, but this is the thing that we need to look into, as we know that when we get older, we have so many medical problems and we have so many medication on board also. So that's the reasons that we need to really check what are the illness that patient have, what medication that patient have, so that from there we go through and rule out the disease and is it where the sleep issue is due to this medical illness, or is it due to the primary psychiatric disorder? Okay, this is another list of the medication inducing insomnia. So this is quite common, I think, for most of our elderly having this, because we check back, at least minimum they will have one of the medication from the list. Because can you imagine that if they have a combination of all those medication, so that's the reason sometimes the sleep pattern a bit disrupted. So usually when they come and see me, I always check the list of medication and I check, is it any recent medication that being added that I can see that in relationship with the sleep onset, sleep issue onset. So that's important for us to check on the medical problem and the medications list. Okay. So after we rule out everything, then when we need to diagnose patient as insomnia disorder. So according to the DSM criteria, so this is quite easy for me for us to remember. They need to have a 3 symptom at least in the 3 nights for 3 months. So everything about three symptom. They have difficulty initiating sleep, to maintain the sleep, and early morning awakening. And this symptom happen in the at least 3 nights per week, and for at least 3 months. So this is diagnostic criteria to diagnose patients insomnia disorder. So evaluation for people with insomnia, as I mentioned earlier, we need to have a thorough investigation, history from the patient. It's all about the history to check whether this is something that new things related to medical issue, medication issue, or is it because of primary sleep disorder. So the history that I mentioned earlier, the sleep latency usually is around 30 minutes. More than that, they maybe have that some issue. And the importance of another evaluation for the insomnia, we need to check whether they have the consequences during daytime. Meaning there are people that they are, for some time they have sleep issue, but daytime they're still able to function. For someone that maybe need the intervention from us, that the sleep getting disrupted, and daytime consequences also they're having the daytime consequences that need us to help with for them to function during the daytime. So the history approach for elderly patients. So again, the history. So how the sleep pattern change and causes, medical problem, medication issue, and basically after that, the managements. Okay. Okay. So generally, if let's say we couldn't find other causes of the insomnia, for example, it's not depressed, it's just sleep disorder. So mainly the treatments is mainly non-pharmacological intervention. But I know these challenges for elderly patients. When you talk about the non-pharmacological changes, they look at you like, oh, I come to see you for medication. So when you try to educate about the non-pharmacological intervention, it's a bit challenging for them. But I always give a try for them to practice on this. Sleep hygiene is something that very important, but actually it works quite well if they are try. And sleep hygiene, stimulus control therapy. This is also quite important. We need to tell the patient that bed and your room is only for sleep. Because I know that some of us that use your room and bed for everything, reading there, watching TV there, and then do some works also on your bed. But this is not advisable for someone that having a sleep issue. So we need to teach the brain that when I sleepy, I go to the room and I want to sleep. It's not that we do all activity in the room so that the brain get confused. When we go to the room, brain think that what you want to do now. You want to sleep, you want to read, or you want to do work. So we need to teach them. So when you feel sleepy, go to the bed and sleep. So if you feel that you cannot sleep, if sleep latency prolong more than 30 minutes, get off from the bed, go out for a while, and then do other things, then sleep again. Try again. This is some stimulus control practice that we can do for patients. And also we can advise them for doing relaxation therapy before they want to go to the sleep. Cognitive behavior therapy for insomnia is also something that we can practice for the patient, but it needs someone that is psychological minded to practice that. And the QR that I show here is basically the sleep hygiene video is by me. So we can share to our patients and our colleagues if they have this sleep issue. So you can share the QR with our friend or colleague, the sleep hygiene video. Okay, so pharmacological management. So before we start the medication, there are lots of consideration of that we need to consider because we need to see that the pattern of the symptom. Is there any factor that may change the management, or we need to consider, for example, risk of fall, cognitive functions also involved, comorbid conditions, age-related alteration in pharmacokinetics and pharmacodynamic, because we know that when we get older, there are some changes in our pharmacokinetics and pharmacodynamics. So we need to consider and choose the medication wisely. So medication review, again, what medications that may involve, that can contribute to the insomnia, and what we want, medication, that choices of medication, what we want to target the symptom. Okay, all right. So I will go through some of medication that we always use for the sleep issue. Benzodiazepine is something that very common, that commonly we use. This is basically GABA A receptor. It's effective in short term. Okay, so it's hard to reduce the stage 1 sleep, light sleep. But it's often, so that's why when it's helped with the light sleep, so it's often correspond with the increase of improvement of the stage 2 sleep and decrease the multiple awakening in the night. However, the problem with benzodiazepine is the tolerance develop quite rapidly, and rebound insomnia can occur if we use intermittently or when we stop the medication. So that is the problem with the benzodiazepines. Okay. So, however, I know the challenges out there because sometimes the only choice that we have is the benzodiazepine. If we need to use the benzodiazepine for elderly, we use that some things that, for example, like temazepam, lorazepam, which is undergo phase 2 metabolism in the liver, go to conjugations phase, because in elderly, phase 2 metabolism in the liver less affected. So that's why the choices of medication, usually we use this type of drugs. And if we needed to use benzodiazepine, we use the short acting. So because it's reduced accumulation and reduce the adverse effect. And be cautious for someone that obese and medically frail individual in elderly, because as we know, when we got older, the proportions of fat is higher compared than muscle mass. So this medication can be accumulated in the fat, so that it will stay longer in the body. So if we need to start the benzodiazepine, we start at a lower dose and titrate slowly. This is in order to reduce the side effect. And if possible, limit the treatment duration around 3 to 4 months, if possible, and try to taper it gradually over these few weeks, and discontinue slowly to reduce the withdrawal symptom. Okay, so this is the one that I said that the type of benzodiazepine that undergo that phase 2 metabolism. There's not much choice. For Malaysia, we only have lorazepam. So that's why we see that some of us in geriatric, we use lorazepam a lot. This is not because of we like it so much, but because it's the most safest for elderly, because it's undergo phase 2 metabolism in the liver, which is less affected in elderly. Okay, so the problem with the benzodiazepine, this is the thing that I always educate to my patients and caregiver, because the risk of dependent intolerance is known, fall and fractures, and risk of the cognitive impairment, and also mortality. So this is the thing that I always worried of, because sometimes they say that it's okay to have the tolerant and dependent because they're already old, but the thing that I'm worried if they fall and break their bones. Okay. So this is the thing that the complications of the benzodiazepine in elderly. So another choice of the treatments, Z drugs. So I think this is quite common also. This is non-benzo. And the example that we have is zopiclone that we commonly use. It is mainly from the study, it showed that zolpidem helped to decrease the sleep latency. So it shortened the period and decreased the multiple awakening at the night. So generally, it improved the sleep duration. So another review said that zolpidem reduced the sleep onset by around 18 minutes. So that's why sometimes it's very helpful for someone that having difficulty to fall asleep. However, the common side effects, headache, dizziness, nausea, and myalgia. And rebound insomnia also can happen is someone that on Z drugs and suddenly we stop abruptly. Okay. This is another new medication, dual orexin receptor antagonist. This is FDA approved for its treatment of insomnia. So this is basically this works at the orexin receptor. The starting dose is at 5 and we can go up to 10 mg, but we still need to be cautious in elderly, because sometimes it's very old group. For elderly, I go to 2.5, even the recommendation is 5. So it's really depend to the clinical judgment. So from the study, it says that improve sleep latency and improve the sleep maintenance, so they can maintain the sleep throughout the night, not much awakening. And the effect, somnolent, fatigue, and headache. But this is quite temporary, because after 1 or 2 weeks, they're on the medication, the the side effect resolve. And from the study, it says that there are no evidence of withdrawal after for patients that use the medication for 1 year, and then they try to discontinue the medication. There are no evidence of withdrawal and no physical dependence. And there's no association with the rebound insomnia when discontinued. Okay, so melatonin, this is quite common being asked to me. How about melatonin? Okay, melatonin is basically a hormone. It's not an FDA approved for treatment of insomnia, but it's basically in Europe they approve for short-term insomnia, but it's not approved in US. But the review in 2020 said that short-term use of melatonin associated with the improvement with sleep quality and sleep onset latency. But there are many other studies said that it's a bit inconsistent effect on the total sleep time. Okay, mirtazapine. So this is quite common medication. This is actually medication for depressions, but it's not FDA approved for treatment insomnia. So the reasons that this medication being used, because this medication has antihistamine mechanism of action. So that's why it help with the sedation. So there are some studies said that this medication have efficiency in treatment of insomnia, but actually FDA is not approved this medication just a treatment of insomnia. It only can be used if someone that having depressions at the same time they have sleep issue, but it's just purely primary insomnia. It's not recommendations. Okay. So like we said that earlier, that patient with depressed also can present with insomnia. So this is another best choice of the medications. Okay, amitriptyline. This is also quite common that I see that patients was given this medication for the sleep issue. This is the first generations of the antidepressant, and these have also histamine blockage of the receptor. So that's why it have the sedation effect. It's quite commonly used, especially sometimes when I worked last time at the KKM at the primary level. So they use this to help some patients with the sleep. But actually, there are no evidence for the effectiveness for the insomnia, and it's not recommended for the insomnia. However, low-dose amitriptyline, it shows that some improvement for someone that having sleep issue, and at the same time, they're having the chronic pain. So this is useful for this type of patient, but it's not just purely insomnia. Okay, quetiapine. This is another antipsychotics that have the histamine 1 action. So that's the reason they have the sedation effect. So there are some studies said that there's investigations said that the efficacy of quetiapine compared than placebo in the primary insomnia is helped to decrease sleep time and decrease the sleep latency, but it's not really statistically significant because the sample size is quite small. And common side effect: dizziness, dry-mouth, weight gain, constipation, and movement problems. So that's why if for someone that having insomnia issue but no other medical, for example, no on top of the depression, we are not use this medication for the sleep. Okay, this is under another common medication that being used over the counter. Antihistamine medication is also have the histamine receptor blockage and causing the drowsiness and sleepiness. I think it's quite common because easily available and you can buy anytime that you want. So it may slightly improve the total sleep time over the night. But there are so many other side effects because, as we know, this medication is also have a lots of this medication have long life. So causing the grogginess, particularly if they take higher dose, and anticholinergic effect with this medication, such as they can cause dry mouth, urinary retention, some confusion, and memory impairment. So that's why it's not advisable, especially in elderly. Okay. So this is actually my summary table of all the medication. I try to summarize it in one table to see that, okay, what's the mechanism of each medication, the efficacy in regards of the sleep improvements and indication. So whether or not can be used in elderly especially. So I hope that it can be some guidance for us to choose which medication that we can choose if, let's say, we encounter patients in the elderly with the sleep issue. So as conclusions, the sleep difficulty is not a natural consequences of aging, like what you always thought of. So insomnia is always multifactorial, as mentioned earlier: medical problem, medication issue, and maybe the psychiatric comorbidity, and can be due to the secondary causes, example, mental health problem, for example, sleep disorder, medication effect. And comprehensive checkup, medication review is important before we conclude the diagnosis. So the medication, hypnotic, for example, benzodiazepine, Z drugs, should be prescribed with caution. It can prescribe, but with cautions. And we need to remember, in elderly, drug metabolism is affected. So we need to be very careful, start at a lower dose and go up slowly. So with that, I thank you.
Thank you, Dr. Surina, for the excellent presentation. And I'm sure we are all appreciative of her sharing her insights into a very common problem among our elderly population, namely sleep concerns. So we are already at 9 o'clock, so I think we have time for one quick question. I'll hand it back to Dr. Surina.
Oh yeah, about the magnesium, yeah. This is another common question I'm being asked when I give a talk of the insomnia. So magnesium supplement is there are some studies says that it's help because magnesium can help to give a calmness to a patient, but it's not all magnesium. We need to be very specific. If they said we need the magnesium supplement for a sleep issue, they need to find the magnesium glycinate. So this is the type of the magnesium that is usually helpful, but it's not like the sleep treatment is more like the sleep supplement to help them with the sleep. Okay, another question. Patient is denial, mostly refuse to sleep hygiene. Yeah, I know these are the challenges. These are the challenges, especially in early. They're not happy. They don't like it when we ask them to do the sleep hygiene. In primary care, if let's say I need to choose the one drugs, for example, I know primary care we only have limited choices. I will go for the lorazepam if you have. If you don't have, you choose any of your benzo which is short acting. For example, Xanax, clonazepam should be okay. So this is the choice that I always suggest to my colleague in primary care because I know that our limitations. Okay. And melatonin, this is more on the sleep aid rather than the treatments, and it's not actually approved by the FDA for the treatments of the sleep. And the problem is, I think, is not that it's not available in Malaysia because I checked before in the pharmacy outside. It's not available because some of my patients get it from Singapore. Because last time I worked in Johor, they get it from Singapore, or some of them get it from Australia. Some they said they can buy from Shopee, but I'm not sure uh, 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 whether it's the real melatonin or not. But they can try to use it if they works for them because it really depends on people to people. Some works with melatonin, some is not. Okay, I think that's all. Oh, two. Zopidem.
Okay, thank you, Dr. Surina, for all the presentation and the answers to the questions. So if there are any more questions, I'm sure you all can email Dr. Surina directly at her UM or UMMC mail. So thanks to Dr. Surina again, and thank you all for joining us for this edition of Breakfast at UMHealth, and have a good rest of the week ahead. Thank you.